Thank you for your kind introduction. First of all, I'd like to extend my warm welcome, all of you, to Apple 2023 as one of the hosting chairmen. And also, I'm very happy to meet you face to face through the long tunnel of COVID. Furthermore, I'm very honored to give a lecture regarding local ablation, the update. Today, next 18 minutes, I'd like to answer for 3 questions. A very common question. First question, where are we now? Second, what's the matter? Third, what comes next? Shall we start first question? Where are we now? In other words, what is the current status of ablation in HCC treatment guidelines? Before answering to this first question, I want to tell my story. During my sabbatical leave in 2018, I had a chance to meet 3 senior doctors who developed local regional treatment for the first time. They are all alive and they are very actively working with 80 years of age. As you know well, Asia is the birthplace of local regional treatment. We should be proud of it. During the 4 years since the first development of local regional treatment, we have published many papers regarding tumor ablation. According to the review paper by Dr. Liang Ping, almost half of the paper was published of the founding country, including China and Japan and Korea. This is the famous 2 landmark study to report the outcome of radiofrequency ablation with more than 1,000 patients from Japan and Korea. As you can see, the 5-year survival rate is about 60%, which was the best at the time, 10 years ago. This is the current update our data. As you can see, the 5-year survival rate is about 83%. There was a significant improvement during the 10 years. What about the surgery versus ablation? I think this is a long-standing debate, but I think many of you in this room will agree with this summary. So definitely, overall local tumor control is better by surgery, but overall survival quite similar. Ablation is more safe and cost-effective treatment compared to surgery. There are a couple of studies reporting the cost-effectiveness compared to surgery. RFA is more cheaper. I like to mention this famous randomized control trial from Japan. The many Japanese researchers from 49 institutions reported a comparative study between the surgical resection and ablation for smaller than 3 cm HCC. As you can see, even recurrence-free survival rate, there was no significant difference between surgery and ablation. And also, non-randomized cohort trial shows the comparable result between the surgery and ablation. After this study, we can say ablation can be considered first, even if surgically resectable for early stage HCC. What is the ablation status in treatment guideline? As we all know, liver transplantation, resection, and ablation are the treatment choice when available and feasible because of their curative potential. This is the summary of ablation in treatment guidelines. As you can see, ablation is accepted as a curative treatment option for very early and early stage HCC in major treatment guidelines. Recently, Korean Liver Cancer Association and National Cancer Center revised the first revision for practice guideline. As you can see, the RFA is recommended as the best option for early stage HCC, supported by the level A evidence. In the recent revised BCLC guidelines, As you can see, the ablation finally survived as a treatment option for very early and early stage HCC. So the answer to the first question, as we know well, the ablation is in the old treatment guideline based on the evidence we have made together. Moving on the second question, what still matters for successful ablation? As we know well, tumor size, tumor location, and tumor biology still matter for safe and complete ablation. Small tumor size and big tumor size is still a problem. Thanks to the technical advancement of imaging and contrast and also surveillance, the tumor size detected is very continuously decreasing. But however, we have several solutions depending on tumor size. For larger tumor, we can use more powerful microwave ablation, or also we can combine TACE. For smaller tumor, we can use fusion or contrasting and ultrasound. Location is the critical part for successful ablation. Many physicians still have concern about subcapsular, perivascular, and periorgan tumor. However, recent many studies demonstrated there is no significant difference in terms of outcome according to the location. Because we understand the technical difficulty and apply assistant techniques and modify ablation protocol. For example, for subcapsular tumor, currently we are using the multiple electrode or at least overlapping ablation with single electrode to minimize the recurrence. And for perivascular tumor, this is a very sticky tumor because there is a dilemma between the potential heat sink effect versus vascular complication, including infarction. And also, this kind of study is very difficult because perivascular tumor shows very broad spectrum. But we have the couple of solutions for this kind of perivascular tumor. To overcome heat sink effect, we can use more powerful energy source microwave, and also we can use the no-touch multiple RFA using the bipolar technique, and also we can combine TACE or ethanol injection. What about the peri-organ lesion? There are many organs that can be averted to the ablation zone. However, artificial fluid is the universal technique to prevent thermal injury at the moment. Let me show you two cases for hepatic dome ablation using fusion and artificial fluid and contrast nasal ultrasound. This is the how I make artificial ascites in ultrasound room. We are using the angiography introducer sheath rather than spinal needle. The tumor is very small and located very high. So the tumor is barely seen after skin anesthesia like this. I insert electrode when I instruct the patient of breathing status. I insert electrode just the subcapsular portion of the liver, 5 millimeter. After that, I instruct the patient to breathe out. At that time, usually the sheath is placed in the peritoneal space and insert the guide wire and check the location of the guide wire, whether it is located between the peritoneum and the liver capsule. And then change the angiography sheath like this. And then rapid infusion of DW solution up to 1 liter. maybe in 2 or 3 minutes, the Sony window is completely improved like this. So we can see this kind of a tiny tumor confidently after then insertion of the applicator. So we can separate the liver from the diaphragm like this. The yellow circle means the tumor boundary. Red circle means our target volume to be ablated. And start the ablation, you can see the echogenic bubble within the red circle. And during the ablation, we can check just 5 minutes after the ablation, we can get this kind of successful ablation joint with providing safety. And track ablation, there is no bleeding on Doppler ultrasound. Even compared to laparoscopy ablation, you can see minimally invasive. Pre and post. A second case is radiofrequency ablation with artificial pleural effusion. There is a 2 tumor in segment 7. To make artificial pleural effusion, we prefer the semi-erect position to minimize the fluid amount. After puncture the CP pleural space, you can see the fluid in the pleural space like that. The Sony window is much better. And after the first ablation from deeper portion, and then move the superficial portion using the 3 electrode. Pre and post, quite successful ablation. So currently we don't worry about the thermal injury if you use the artificial fluid like this. The final factor for local ablation is the tumor biology. For example, high tumor marker, the microvascular invasion, LLM feature on imaging study. If tumor has one of these findings, we should be careful. We should consider more curative option, including surgical resection. As you can see from our study, the tumor shows a MRI finding of MVI shows the worse result, and also MRM finding shows the worse prognosis, more frequent recurrence compared to ordinary LR4 or LR5. The Korea is the most resistant. Korean doctors most resistant to microwave ablation. I think there is 2 reasons, as you can see. Microwave ablation is definitely a stronger weapon compared to radiofrequency ablation. However, for example, for 15 years ago, my old friend Fred Lee actually developing microwave ablation. He told me, "Oh, poor Dr. Rim, RF is almost dying, but still alive," because there is insufficient evidence microwave ablation shows a significant survival benefit, even in randomized controlled trials so far. The Korean researchers, including Professor Jung-Min Lee, they continuously develop this kind of nice radiofrequency ablation, supporting the no-touch technique. The several papers reporting the outcome of no-touch technique. You can see the result was very excellent, which is comparable to the best result of microwave ablation so far. Currently, this group reported the no-touch radiofrequency ablation guideline in Korean Journal of Radiology. So if you are interested, you can take the basic information, especially for beginner. What about the solution for biology? Careful selection is really essential. We have to exclude this kind of a potentially highly aggressive tumor from the conventional ablation. We should consider more curative option, including surgical resection and multiple RFA or combined treatment. Ablation is still has a matter. We have size, location, and biology, but we have the novel system technique to overcome this limitation. Moving on the final question, what comes next? What is the next? There are many kinds of trial to achieve accurate and optimal ablation for guiding and assessment. But although looks very promising, but the use of this kind of software is not so much popular compared than we expected. And also most software is based on CT guidance. Cryoablation and ILE is a good energy source for periductal and perivascular tumor, but cryoablation needs longer procedure time, and ILE is pretty expensive. One new case on the block in the field of ablation is a histotripsy. Histotripsy is a focused ultrasound technique resulting in the mechanical tissue fragmentation at the focus of VR sonification. And currently, one device is under clinical trial. Maybe near the future, we can see one new non-invasive treatment technique. What about the role of ablation in adult immunotherapy? There are many studies reporting the immune reaction after local regional treatment, and also there are many ongoing studies regarding local regional treatment with immunotherapy, and also there are many adjuvant immunotherapy after local regional treatment. But if validated, these treatment schemes will need adequate patient selection in order to maximize research. So we need to wait to taste this kind of wine, which kind of wine will be best from this oak barrel, maybe in 5 years. So I think we have been too local for almost 30 years, but I think it's time to move beyond the local to precise and optimal and liver-conserving ablation. Noble is beautiful, but remember the words. So let me conclude my talk.
Professor, thank you for your beautiful slides and contributing as lecturers. Now this topic is open to questions or comments from the floor.